And we are back. All right, I hope everyone had a nice breakfast, lunch, or dinner, whatever time zone you're in. We are going to continue this discussion in a very interesting twist to the day. The title is Firearm Injury. That has a lot of different topics can be related to that. And so a lot of them relate to us in different aspects, both clinically and in other aspects. And we recognize that this may be a United States-centric discussion, but we can talk about that too. So with us, we have Dr. Rick Pearl, Dr. Peter Masiakos, Dr. Marion Henry, and Dr. Bindi Naik, and they are going to be leading the discussion on firearm injury in children.
Thank you, Todd. So I think they're going to be clicking for us.
They're going to be clicking for you.
Go ahead, Peter.
Peter, go ahead.
Okay. Thank you. So yeah, this is definitely going to be a change of pace. We do have one case to discuss, and then after that, we're just going to have a little bit of discussion regarding gun violence and what we can do about it as surgeons. So this is a 9-year-old. He was an innocent bystander, which often happens with children where they're just caught in the line of fire. He was brought to the trauma center soon after he was shot. When he came in, he looked great. His vital signs were stable. He was asymptomatic. He was sitting up and talking. And he had an entry wound in his anterior chest. We got an x-ray, and it looked like that, very scary. We did a quick fast. There was no pericardial effusion. The chest x-ray just showed a small left effusion. A chest tube was placed, which had very minimal output, no air, just a little bit of blood. So then we got a CT since he was totally stable. And I'm not sure if you can make it out there, but there's a big bullet lodged just anterior to the descending aorta where you kind of see the artifact, millimeters from the atrium, from the pulmonary artery, just sitting right in that little crook there. There was no clear evidence of aortic injury. There was no pseudoaneurysm. There was no dissection. A kid's still totally stable. So what would you do next?
All right, so what would you guys do? Or do we have a poll for this one, Ellen? All right, so while we're waiting, so you have a gunshot wound. You can see where the bullet is. It looks like the child is stable. You do a thoracotomy, thoracoscopy, or observation. What would you guys do with this patient? Mark, I'm going to call you. Observe. What Ken says observe. Would anyone do something different than observe? What does the poll say? Most people are saying admit for observation. All right, let's keep going, Bindi.
Okay, so that is what we did. We admitted for observation. We admitted him to the ICU, continued to stay well. Next slide, please. He did great. After a couple of days, we couldn't think of any other reasons to keep him, so we discharged him. But we decided to get a surveillance CT 1 week after injury. I'm so glad we got this because it showed a pseudoaneurysm. So he got this as an outpatient. He went home. I got a call a few hours later saying he had a pseudoaneurysm. We rushed him back in the hospital, admitted him to the ICU, put him on some blood pressure control, even though his pressure was actually fine, and then tried to decide what to do. So how would you manage this? Is there a poll for this?
Yeah.
Okay.
So open graft repair, endovascular stent, and then regarding the bullet, would you leave it or remove it? So open repair or endovascular stent or something else?
Well, we didn't give you a choice for something else.
No, I'm adding that.
What did most people...
We're waiting for we usually have to wait about 30 seconds. So any thoughts in here? Mark? Keep looking at me. So if you look at me, I'm going to pick on you. Yeah.
Picking on me. No, I think this is a perfect candidate for an endovascular stent.
Okay. Yeah.
I would agree with the endovascular stent, but I also wondered, and I was too chicken to raise my hand, but would you consider getting a CT angiogram initially when the child, rather than at the time of admission? Because I think, and I'm not a radiologist, that a lot of these injuries are actually visible on CT scan.
This was a CT angio.
It was a CT at the time of admission, even though he's at the time the child was, you got this CT
The
1
first
week
scan?
after.
Yeah, the first scan
Didn't show anything.
didn't show anything.
And was an angio.
It was a CT angio,
Okay,
correct,
sorry,
yeah.
thank you.
So what did the poll show? What's the...
Wait. You said Ellen, I'll repeat it.
80% said stent.
Okay.
80% say stent. Oh, Chuck.
Aren't the stentors worried that with the aorta pounding away on that thing over time that it's going to erode into something?
Okay. So there was a couple issues with the stent. So we talked about the cardiac surgeon about open repair. He said, you'd have to go on bypass for this, and we could do it, but it's not ideal. And we talked to the vascular surgeons, IR, about stents. So a couple of things: the stents that people use for TVARs are not made for pediatric sizes. They're very long. They occlude a lot of lumbars. They don't grow. So as this child grows, this is a small child, small 9-year-old, as this child grows, it would there would be a stricture there. The way they put them in, they expand it with a balloon, and they're very nervous about expanding that injury. So we ended up talking to a cardiologist who ended up using the stent that they use for coarcs. So it was much shorter, smaller, and the way they deploy it, I guess it's a much softer balloon or something like that. Of course, we did it with backup, a sternotomy ready to go if we needed to. Luckily, all went well, and the stent was placed. The kid did fine. We discharged him after a few days, but then there's an x-ray. We were debating what to do with the bullet. So it's a large bullet. A lot of times we leave these in, but there are some risks to leaving these bullets in. So what would you do? Would you take the bullet out, or would you leave it in place? Interesting.
Repeat that, Bindi.
Okay, so 56%, well, I guess that's not most, half said that they would remove the bullet. There was a lot of debate at my institution. Why would you bother? There's a lot of risk involved given its proximity and stuff like that. The literature really did not help. I took a poll and asked a bunch of people around the country, including my friend Rich and all these other people, and finally decided we're just gonna remove it just because of the risk of fistulization or anything like that, given how close it was to all these structures. So went in with VATS, next slide please, went in with VATS with the cardiac surgeon on standby. And I wish I'd taken a video, but basically you could see the bullet there was in a little abscess cavity. And because the stent was protecting the pseudoaneurysm, I felt, a little bit more comfortable with just pulling it out in case it was buried into the wall or anything like that. And it came out pretty easily. It was a huge bullet, and you could see that pointy, sharp edge of it from where the blast was. And so in the end, I'm glad we take it out. Kid did fine, went home the next day. Follow-up CT 6 months later, did great. 1 year later now, is doing fine. And so if this aortic coarc stent is expandable, and as he grows, and so as he grows, we'll get scans on him and see if we need to expand it. So that was the case. Does anyone have any comments before we move on?
I guess one question, there was an interesting PTS survey that just went around recently around retained bullets and thinking about lead levels and all of those things. Do you have thoughts on that and whether or not you worry about measuring lead levels or anything like that in the long term?
I have left a lot of bullets in a lot of kids and have never measured lead levels, but it definitely made me think that maybe we should be measuring lead levels.
There's a lot of soldiers with a lot of lead in them.
So I don't know if it's true or not, so I'll qualify with that. But I remember reading somewhere, someplace that metal lead like that in a bullet is not like the lead in paint that you're eating or anything like that. It doesn't leach into the body and does not increase lead levels. But a lot of bullets are no longer lead either, so there are other metals.
True, but I don't know. There is a lot of literature coming out about this. I think there was a study by Kenji Naba in the UCLA group about measuring lead levels and that they were higher in adults, and so. I'm not sure if the bullets have changed or what, but I think it is a real problem. And how often do you measure them, for how long? This is something that needs to be studied further, for sure.
We are hearing from the audience that they're having a hard time hearing from these mics, so put it almost on your lips and yell. Okay, Sean.
So what's unique about this case is you already had an injury from this bullet. When we were having the conversation about whether we should take it out, you already had a tissue injury on a vessel, and now it's probably going to propagate. But I think foreign bodies that are in and around the heart are going to be potentially treated a little bit differently than when we normally just consider leave them no matter where they are, because with that ongoing beating that can create some progression. So we had a patient that had a BB gun shot ended up inside the pericardium. Big debate with our cardiac surgeons. We decided to watch. A friend of mine had a similar case, so we said, well, let's put together a little case series. In writing that discussion, what I found was that the long-term history of these things is not good. So while I was writing this case series to make the point that you might be able to leave these things, I was left with the conclusion of, no, you really shouldn't, because they were talking about people who were showing up 20, 30 years later with sudden cardiac death, with electrical abnormalities, people who had shrapnel from war, that they frequently end up finding their way into the muscle and creating a major problem. So this same patient ended up coming back before we even got the submission and had a pericardial effusion, and the cardiac surgeons did a subxiphoid exploration. They opened the pericardium. The blood rush that they got, they immediately did a sternotomy to control the bleeding.
Wow. That's great. Thanks. And another point about this case is that I'm glad we got that CT, a follow-up CT 1 week later, because there was an injury from the blast effect. And so I think if you had gone in and just removed the bullet when he came in, you may not have thought to get that follow-up CT. I don't know. There's no good guidelines around that, but and very, very few papers in the literature about pseudoaneurysms from penetrating injury. So. Okay, so next slide, please. We're seeing a lot of penetrating trauma in the U.S. Sadly, it's now the leading killer of children. Next slide, please.
Who's got the clicker?
Peter does. Okay. So in your practice, do you manage children with firearm injuries? There's a few questions here on the poll. I don't know if they're all together or separate, but
Yeah.
okay. In your practice, are you the primary trauma surgeon or assisted by adult trauma surgery? And then have you noticed increased incidence of pediatric firearm injury in your city or state?
So Alan, you have this microphone if you want to. There you go.
People are still answering. It looks like most people are saying yes, that they manage children with firearm injuries. And then a little bit more than half are saying that they're the primary. And the vast majority are saying, 75% say that yes, they've noticed an increase. The answers are still changing, but.
Okay. And we didn't specify. Is this on? We didn't specify, but it seems like it's off, right?
Keep going.
Okay. We didn't specify, but it'd be interesting to know if our international audience sees less than we do. I'm guessing that we do. Just in talking to some people here, they see 1 or 2 a year, and we see 1 or 2 a week in Houston, at least.
Right. So that's the big question that we're addressing here is there an equal incidence that we're seeing internationally that we are in the United States? So maybe there's no question for that, but because we can't tell demographics from the polls, but maybe put it in the chat. Yeah, Cecilia.
In Argentina, the problem is, or I don't know if it's the problem, but they'll probably go to an adult hospital, so we don't see it as much.
Even the little kids.
Even the little kids, yeah, okay. Because we have more adult hospitals, and they are more prepared for trauma, so probably they have it.
It's a great transition to my next. I think we should let's just skip this. This
okay. Next slide, Peter.
So yes, that used to be the case here as well. Is penetrating trauma usually happen in older adolescents, and they would go to an adult trauma center. Because we're seeing more and more, I don't know if this thing is on, but anyway, because we're seeing more and more firearm injuries even in younger kids, they are now coming to the pediatric trauma centers. And especially if you're at a freestanding children's hospital, that's a pediatric trauma center, we are now having to relearn how to take care of children with firearm injuries. So some people that maybe haven't taken care of one in many, many years, and also to set up the hospital. So that's what this is about. So there are some differences from blunt trauma. In ATLS, it's pretty much focused on blunt trauma. There's very little teaching actually for penetrating trauma. So one of the things we've done at our hospital is have simulations with the emergency room and have lectures about this on how you manage penetrating trauma differently from blunt trauma. So first of all, the main thing is time is of the essence. You want to get these kids to the operating room as quickly as possible. There's a much higher likelihood of rapid massive bleeding. of needing an OR, chest tube, or ED thoracotomy, and that potential injuries are directly determined by bullet trajectory. Next slide, please. So you want to get really quick x-rays. X-rays are very helpful. Click. So for example, on this kid, if the bullet could have either gone down into the pelvis or, next, click please, or up into the chest, click please, up into the chest, and that really determines what might have been injured, and maybe if you need your cardiac surgeons there, it's really helpful. So just teaching the emergency room physicians and residents about this has been really helpful. I came up with this modified ATLS principles for penetrating trauma. So A, for airway, unlike in other blunt injuries, we try not to intubate until it's absolutely necessary. Save it for the OR in case they're hypotensive, and also you don't want to waste time. B, bleeding. So if it's a chest gunshot wound, place a chest tube on the injured side. There's not much else you can do. C, tourniquet if there's an extremity injury, plus minus. Pressure, blood, activated the massive transfusion protocol. D, disability, doesn't matter unless there's a GSW to the head. E, roll, which is exposure, so roll and identify our bullet holes. And then for secondary survey, limited to bullet trajectory based on x-rays. We don't care about the tympanic membranes and all that other stuff that they normally look at with blunt trauma. And then D, disposition, get to the OR as fast as possible because minutes matter. So next slide, please. So there are, it may be necessary for more and more children's hospitals to kind of get used to this, sadly, until this epidemic goes away, if it ever will. There's courses that you can take here in the States. One of them is ACID, trauma surgical exposure techniques for people that may not have done trauma operations in a long time, because most of what we do in pediatric trauma is non-operative now. Massive transfusion protocol, if there's not one at your trauma center, you need one. Simulations are very helpful. Endovascular options, if you don't have vascular surgeons on staff, or IR, your IR people don't have the necessary equipment, then that needs to be done. And then plus minus on mass shooting drills. We actually did one of these once, and it was really traumatizing to the children, so stopped doing them. But it did show us that we're really lacking in a lot of resources if it actually did happen. So,
how many of you learned how to use Rabo? Anybody? No.
Yeah, that's the other one. So Rabo, I think there's some controversy even in the adult trauma centers. Some centers like it, some don't. But and the balloons are not small enough for children at this time. But it may be something that's coming down the line. Any questions on that? Any discussion? Okay, great. I think Peter's taking over from here.
So Pete Masiakos coming to you from Boston. Sorry I can't be there in person. Thanks, Bindi, for presenting the topic of treating the injuries. And as we all sit in this room and think about it, even our international guests, I think this is one topic that the three of us, Bindi, Marion, and I, and even Rick, feel that if we were put out of business, it wouldn't come too soon. So the next part of the talk is sort of geared towards the prevention strategies, some novel ideas of where we've gone with this and how we can try to prevent the injuries from happening in the first place. For the first time in recorded history, firearm injuries in children have exceeded motor vehicle crashes. And to be talking about how to deal with these injuries, as Bindi has just talked about, in relearning what we learned in our general surgery rotations as pediatric surgeons is pretty profound. The deaths from suicide and homicide are both on the rise, particularly in very young. And the question that I have for the audience is, do you or your institution promote safe firearm storage for families in anticipation of trying to impact it? Or do you or anyone on your team routinely ask families about access to lethal means, particularly guns in the home?
So what about, let's talk about some of these institutions. How do you guys, do you promote safe firearm storage for families? Do you talk about it? Yes, your institution does, or you do? I'll be honest, I've never done it, and I'm going to be honest here.
So actually, Todd, we do have a firearm injury prevention program in Akron.
That's not what I'm saying.
Oh, you don't? You don't address it? Okay. No, because I think our trauma nurse practitioners do, and we also talk about safe gun storage, and there's a program out in the community with gun locks. I know we did that in Atlanta, and I think we do it in Akron as well.
So at Cincinnati, there are definitely individuals who do. I would agree with you that I think it's not standardized across the institution. We are in the process as part of an institutional firearms task force about standardizing both how people teach and how we teach trainees and others to think about counseling for firearm storage, and then making sure that we have resources. We do within the Injury Prevention Coalition have some resources for lockbox, but they're not widely available. So thinking about how we make sure that those resources are available enough that when we ask families if they want them, they actually can access them.
Do we only talk about firearm safety and storage in patients that come in with firearm injuries? So every trauma patient or motor vehicle crash patient?
So Todd, the AAP has all these questions pediatricians have to ask patients, and one of them is, are there firearms in the house, and are they appropriately locked? What I don't know is if any of our institutions, and Mira, I'm curious to hear what you do, have you engaged the primary care doctors to say, here are your resources if anyone answers yes? Because my guess is that the pediatricians all ask these questions, and then when somebody says yes, they're not quite sure what to do.
So a couple of things. In Ohio, there's the Ohio AAP actually has a statewide initiative around lockbox availability and gun locks. So we're using that tool. Our primary care pediatricians have been really engaged in this process, and so they're actually thinking a lot about how they access those resources. Okay, should I keep talking or no? Okay, so I think, and then the last part is really, we are trying to standardize that more broadly so that we make the resources more available, but also we train everybody. And to Todd's point, we want to screen everybody, just like we screen for bike helmets, just like we talk to people about seat belts, injury prevention. Secondary injury prevention is great, and HVIPs and all of those things are important from a recidivism standpoint, but primary prevention matters most, and if we can avoid stress and injury at the primary level, that'd be better.
But also to your point, Mark, the HVIPs, so basically knowing, not every hospital has to have a formal hospital violence intervention program, but it is important for them to know what the community resources are when they say yes. And also most pediatricians are not asking that question, at least in Texas, because they're too scared to defend patients. And so that's something that we're working on. But it's not just up to the pediatricians, we really should be doing it as well. Okay, Peter, you're back.
All right, so I'm back, and the reality is not unlike anything that I just heard people talk about. The trepidation with which we want to ask, the depoliticization of a topic that's inherently political, and the approach in the medical community, which has been claiming that this is our lane for the last 5 years to identify the next 10 words in that. I think that it's clear that this is in the media. It's clear that it's on everybody's radar. In a paper that one of my colleagues wrote at MGH, it brought to bear what happened in America in 19 days after the Uvalde shooting. And the reality of 2,300 deaths, it is tantamount to a public health crisis that we typically would respond to emphatically. In taking that into context, most of the deaths are still assault homicide related, even the non-fatal injuries, but a large cadre of the injuries are due to self-harm or unintentional injuries that we see in kids. But going back to the question of whether we ask, we started looking into our own databases, and at MGH, MGB, we looked at how many times the documentation of firearm access appeared in the medical records, whether it be in a medicine, neurology, OBGYN, orthopedic, psychiatry, and surgery record. And it was pretty abysmal. Where we ask about alcohol and tobacco, the ask and recording of firearm access, even in lethal means access, was woefully small. And this is 80,000 data chart reviews to find the words for gun access, firearms, or self-harm. But in order to provide a little bit of context into what we need to be asking and how to ask the questions, we looked at defining our program as a community-driven program. First, we looked at actually what's happening in the emergency department, and in order to get the answers, to teach the students what to ask. In kids who presented to our emergency department in 2018, who had suicidal or homicidal ideation, only 5% of the kids were asked about whether there were access to lethal means in the home. That's also parents. So we instigated a sim class, a curriculum where each incoming intern since 2019 is given a 30-minute didactic going over the details of gun violence within Massachusetts. And then they spend 30 minutes times 2 talking to a standardized patient in a curriculum that was developed by the residents in each program about talking to a patient, whether they're receptive or opposed to the question of whether they have a gun in the home. And what we found is that people did it. There were no opt-outs. There were no concerns about comfort. There were no issues about whether or not it was the right thing to do. As a matter of fact, it kept going. And the buy-in was so great that we had every resident doing it in every curriculum. And in 1 year, we reevaluated the question about whether this was being documented in the emergency department for that vulnerable population. And the documentation went from 5% to 32%. And although this is a great response in 1 year, we still feel that we had work to do. The problem with our curriculum is that it is a pretty expensive curriculum. It costs $125 an hour to have the standardized patients who are actors hired to be present at all of these events. And it costs us about $50,000 a year, which we're funding on our own with grants. We actually communicated with a group at Cincinnati Children's Hospital to see if we can make a different approach to this, just like they've been doing with vaccines and looking at virtual reality or artificial intelligence generated platforms. And Joe Reel and Matt Zakoff at Cincinnati Children's Hospital have designed a library now of avatar-based curricula. And we're starting to animate, and we're going to do a proof of principle with respect to whether or not this platform, which is easily expandable, easily transportable, can be used in the same way that our curriculum has been used. The other approach that we've been taking is going to the community. We always hear that Boston is the safest city and the safest state in the country as far as gun deaths are presented. And if you present mortality by state, that's true. Massachusetts, except for Hawaii, is the safest city in the safest state, Boston being 40 deaths per year. However, if you look at shots fired, it's a different phenomenon. And if we start sort of moving away from the idea that we're only counting deaths and looking at gunfire and gun-related incidental trauma, for example, we find that from the Boston PD data, there are about 1,000 to 2,000 911 calls for shots fired, and most of them happen between the hours of 8 and 11, which portends a bad sleeping habit for kids in these neighborhoods, and particularly the one neighborhood in dark red is right smack dab in the middle of the place you would expect, which is Roxbury. So deaths, we have to reframe into injuries and shots fired and community fear. And the community is being uplifted through the program to participate in the education of our residents in a trauma-informed way by bringing the community into the classroom and understanding exactly what they do insofar as dodging bullets for a living or not sleeping through the night because they're woken because of a gunshot or a siren. About 2 years ago, Khan and I walked to Emerson College, which is a film school down the street from MGH. And we asked the film folks if they can help us identify a way that we can raise the voices of the community. And in a collaboration that's going to last for at least 3 years, which is funded now, we are embedded in the classroom, and there are 3 classes per semester that are done at Emerson College, bringing what we call community educators who are paid to present their side of the story to the kids who are going to be writing the future narratives of gun violence. And I'm going to share with you this video. It's a short video about the program, and then I'll be happy to entertain questions.
That's not our Boston.
That's not our Boston.
Esto no es mi Boston.
Este não é meu Boston.
That's not my Boston. Si pa Boston no. That's not my Boston.
Children don't deserve to be killed. They don't deserve to be shot down.
For every person shot by a firearm, at least 10 immediate family members are impacted. Repeated gun violence and the systems that perpetuate it lead to trauma for individuals, families, and entire communities.
Child dies in the emergency room from a gun wound and nothing happens.
Coming into the hospital and somebody making a cold remark like, which one are you here for? Because there were multiple people who were shot that night.
To make that John Doe or unknown male a person, right?
How is it that journalists are covering these stories and are choosing these sensationalist headlines instead of in-depth reporting? How is it that policymakers are making decisions about how to allocate funding without really understanding the voices and the stories of the communities whose policies are affected directly by this?
We are a community
of storytellers,
lifting up the voices
of those most impacted by
gun violence in our city.
Every day in Boston, neighbors are coming together to support one another.
For individuals like me, who were formerly incarcerated, we do commit to the uphill journey of building a new life and paving new pathways for those who will come after.
Transforming narratives of gun violence is a collaboration between the Engagement Lab at Emerson College, the Center for Gun Violence Prevention at Mass General Hospital, and the Louis D. Brown Peace Institute. Through co-created documentary, interactive and immersive media, games, journalism, theater, and more, we are inspiring solutions and interrupting cycles of violence by focusing on what people have, not what they lack.
Social Impact Studios are semester-long experiences at Emerson, where students and faculty work alongside community members to understand the roots and impacts of gun violence narratives in the media, so that they can create new ones.
The initiative is guided by a collaborative leadership team, including members of community organizations, doctors, elected officials, faculty, and students. The leadership team guides, amplifies, and distributes the narratives we make together.
To healing, to peace, to sustainability. What are we transforming to a better community?
Narratives we make together.
To healing, to peace, to sustainability. What are we transforming to a better community?
Peter, let's hold questions to the end. We'll move on to Marion's section. Peter, let's keep going. We'll move on to Marion's section with the questions at the end.
And then Marion, let's try to see if we can make this interactive and bring the people in here and see what we can do. You know, we all know this is a real problem. What can we actually do to accomplish in the next 17 minutes? What can we do to make real change with the group here and around the world?
Absolutely. So I'll start with a few questions to see about the engagement of our audience. So we have a couple poll questions. If we can put those up, please.
They were up. Yep. So it says, I'm engaged. This is the one you want, right, Marion? I'm engaged in gun violence advocacy. Okay. So very engaged. Interested, don't really have time, or don't think this is in our lane. Controversial subject. Let's see a show of hands in the room here. Or you can refrain from answering if you don't want to. Who's very engaged in in firearm advocacy, gun violence advocacy? Got about 3 people, 4 people. Who is somewhat? Who doesn't have time or interest? Who doesn't have time or interest? And who does not think this is our lane? So 4 people answered, which means there's some question about how we all feel. I would say I'm probably like you, Dan. I actually get really into advocacy right after a shooting. And I'm really into it, and then I usually fade back into whatever else is going on in the world that day. So I'm probably not engaged enough. Marion, do you want us to go to the other question?
Yeah, let's move on to the other question and say, especially for those who are not very engaged, but who are either very engaged after a shooting or sometimes engaged or not really engaged at all. How much do you feel, how comfortable do you feel about this? That's what the next question is about.
All right. So yeah, are you comfortable or uncomfortable in the advocacy thing? I mean, and by the way, if someone has a difference of opinion, this room is meant for that. It's a safe space. There's no cancel culture here. If you have a difference of opinion, say it. Otherwise, we'll never get anywhere. Is this something that we should be doing? And if not, are you uncomfortable with it? Is it something we shouldn't? Go ahead, Jose.
Yeah, well, kind of not my problems because I'm from outside the U.S. But I was just wondering, you did a video on that article that said that the number one mortality cause for children right now is gunshot injuries. Is it? Yeah. Right, so we've been discussing a lot on how we can kind of share articles in order to change practice. Do you think that article is well known to not to the doctors, to the public in the U.S.? And can
information helps?
Yeah. So do
on the national news every night.
Okay, that was my question.
I have a question. Marion, I'm going to challenge you. What if the advocacy, what if someone in this room says, yes, I believe in advocacy, and so I'm going to advocate for mental health, because it's not about owning firearms, it's mental health, and as a pediatric surgeon, I'm going to advocate for that. How should we be answering that, where people say it's not the firearm problem, and if doctors are going to get involved, we should get involved in mental health and not firearm? Mira's going crazy here, wanting to answer.
Oh, well, let me, I'll answer a little bit, and then I would love to hear Mira's answer, but I think it's not an either or. This is a major public health issue there's not one realm or one answer to solve this problem. And mental health is a major component of this. And so I think it's great if someone wants to advocate for better mental health resources, more pediatric mental health specialists. That is part of the answer. That's part of the problem and part of the answer. But I'd love to hear Mira's thoughts too.
Many of these conversations, and I think feel very similarly about this, which is that there are lots of reasons for gun violence and for firearm-related injury in this country, and we have to recognize the complexity of those problems and approach them with complexity science and a multi-pronged approach. Any single one thing isn't going to solve this problem. It requires neighborhood transformation. It requires mental health interventions. It requires availability of lockboxes and safety tools to prevent unintentional injury. All of those things are necessary, and anyone who wants to pick one piece of that and work towards that piece, I think is a
I love this. I love the multi.
There are crazy people all over the world, but there's not gun availability all over the world. The real difference between us and everybody else is the availability of guns, not the availability of crazy people. So it's an argument without.
All right.
So I don't disagree that there are people with mental illness around the world, but I also think that addressing mental illness is one part of figuring out.
One part of it, but not the big part.
So
it's one part.
It's right. And so the question is, and this is not where we knew this was going to get into this, and we'll do it a little bit, but I agree with Rick's point, is I don't think there'd be a reason for, unless there is a higher incidence of mental health in the United States, why doesn't Jose ever see it? Is there more mental health problems in the United States compared to Chile? Probably not. It's probably equal everywhere. The only difference is maybe gun availability. So I think as pediatric surgeons, it is in our lane if we decided that we should be teaching this to take a stance one way or the other. Craig.
Just one other dimension I wanted to add to that was suicide rates. Suicide rates amongst our children is huge, and the difference. Thinking about suicide, if you've got a loaded gun at your head, then the evidence shows very much that if you can revisit that 20 minutes later and they haven't killed themselves, then you can work through whatever that suicidal ideation was. Yeah.
What's that Malcolm Gladwell book where he says if you put something at the availability to cause harm, you'll do it much more readily. I forgot that. It's a great book. Other issues, Marion, that we should be thinking about?
So unfortunately, I can't hear any of the comments from the room. I can only hear you, Todd. So I'm not sure what Craig's comment was, but I do, I do think that the availability of guns is a major problem. And, I don't want to stifle any conversation that's going on in the room, but one of the things we wanted to just briefly address is different ways that pediatric surgeons can be involved in advocacy and the different levels of advocacy. And so if that fits, I can keep going or the conversation can continue, but we can't hear.
Can you hear me?
I can hear you, yes.
All right, keep going.
All right. So advocacy can occur on all different levels. And, I would probably guess that everybody in the room, whether they're US or internationally based, is involved in patient-based advocacy, whether it's for this issue or not. But in terms of firearm violence, it's screening for risk factors. So we do know that in patients with suicidal ideation, if there's a gun in the home, the risk of successfully committing suicide is at least 3 times, if not more, that they will be effective. It's trauma-informed care. So knowing, especially in communities where there's a lot of this, that your patients and their families are impacted by trauma on a daily basis. It's asking everyone about firearms in the home and counseling on safe storage, as we talked about, and it's training. But it also goes to systems, communities, and population-based levels. And so that's working within your hospitals, within your trauma systems, and working at your community and population-based levels. So I will very quickly just go through a few different ways that address all this so that then we can bring it back to more of a conversation on what people can do and what people are doing. So, pediatric surgeons have a role as advocates, I would argue. And if I didn't argue that, then I'd be out of a job because that's my job. But and we work very closely with various organizations through APSA, through the American College of Surgeons, through the American Academy of Pediatrics. Advocacy really starts at the local level. So you can get involved by looking at your city or your state. Knowing your own, in this particular topic, knowing your own state laws. So Giffords Law Center, you can look up your own state laws about guns and know where you stand. It also, learning your own state laws about other issues like Medicaid and access to care. American Academy of Pediatrics has great resources on that. So I would say for any advocacy issue, knowing your own local issues are imperative first. Speak Now for Kids is a wonderful organization through the Children's Hospital Association that is a partnership to look at issues that affect our children and how we can be advocates for those issues. Likewise, First Focus is a bipartisan organization that looks at all the legislation nationally that affects children and how it affects them. So no matter what issue you want to undertake or be an advocate for, finding out how the children will be affected because they don't have a voice. We have to be their voice. If you're interested in learning more, the AAP has fantastic resources for training and education and also great state chapter resources. So getting involved at the state level through your state chapter of AAP or your state chapter of ACS is a wonderful way to find out about the laws. But the AAP, each state chapter has a government affairs section that really will help you understand how the laws are in your state. Because this is not just a national issue from a legislative standpoint, but very much a state by state issue too. And then larger organizations that are more, that maybe interact with other areas. So Doctors for America is an organization that I'm very involved with. And one of the great things that this has brought is I work very closely with other types of medical practitioners in this. So a lot of psychiatrists, OBGYNs, internists, so other perspectives on how gun violence is affecting patients and families, and really has broadened the conversations I'm having locally and nationally about it. So then individual steps you can take. This is from an APSA resource that we wrote that is recommending issues. Most importantly, vote. But again, look up the issues both on a local level and on a national level, and then take those next steps forward. And I'm just going to leave this slide up while we turn it back over to the room for conversations or questions.
Okay, I think we're going to move on so we can finish up, Marion. We'll do questions at the end. I'm going to focus in a little bit on some of the issues with assault rifles, which has been in the news a lot. Is my mic working? Okay, AR-15s, assault rifles. They're designed for one thing. That some of you may know, I was in the Army for 29 years, but my first 10 years I was an infantry officer and a helicopter pilot. So I have personal knowledge of how an M16 works because I carried one for a number of years. And I took care of patients when I was a surgeon in Desert Storm. I've taken care of patients who were shot by these weapons. The only purpose of these weapons is to kill people. They're not designed to kill game, target practice, skeet, or other purpose. They're just for killing. And when someone gets shot with one of these weapons, they go down. Next slide, please. So the 9mm handgun is generally regarded as an effective weapon. Its bullet travels 1,200 feet per second, 400 foot per second kinetic energy. By comparison, AR-15 goes 3,250 feet per second and delivers 1,300 foot-pounds of energy. So the relative difference is enormous. Next slide, please. Now this is a video. Can you see what will play, please? If you can skip it for 1 minute, go to the second minute of the video. This gentleman fired thousands of rounds, okay? And he had a bump stock and made it into an automatic weapon. So he was firing 500 rounds a minute. And you'll hear him coming in a second.
Get out of here. There's gunshots coming from over there. Go that way. Go that way. There's gunshots right here.
In terms of the rate of fire. All right, you got the point. You can stop the video and go to the next slide. So this guy took a bump stock, put it on an AR-15, and that bump stock makes it go from firing individual rounds to what you just heard. 58 people were killed, over 500 wounded. In minutes, literally in minutes. So to compare again, a typical 9mm handgun wound to the liver would produce a pathway of tissue destruction in the order of 1 to 2 inches. In comparison, AR-15 round, go back to that slide, please. AR-15 round to the liver will literally pulverize the liver. Much like dropping a watermelon onto concrete results in the destruction of the watermelon. Wounds like this are the ones seen in school shootings like Sandy Hook and Parkland, where AR-15s were used, at high fatality rates. This is a quote from Ernie Moore, the editor of the Journal of Trauma. So when people get shot with these weapons, you don't get to see them very often because they don't get to you. They die at the scene. So these kids in Uvalde literally all died at the scene. Very, very few people who were shot with AR-15s make it to an emergency room. How many of you have actually cared for one of these people, adults or kids, who were shot with AR-15s? Made it to your emergency room? One. What was the injury? Yeah.
Body, it doesn't, but the extremities were pulverized.
Yeah, the extremity came off, I would assume.
Yeah.
Yeah. In the military, the folks that got shot in the legs, arms, or we usually could amputate or fix something. The ones that were shot in the abdomen or chest were dead. These are not repairable injuries. an entry wound that's this big in the front, the back is blown off. So this nonsense we hear politicians talking about, oh, people should have these to go hunting or shoot a varmint or this kind of nonsense. It's ridiculous. It's truly ridiculous. These are weapons that were designed to kill people in war, period. That's what they're for. And any other use is irrelevant. Next slide, please. So this is one of the many companies that make these weapons. This is Daniel Defense Company. I picked this one because they're the one, this is the company that made the weapon for Uvalde. So you go to their website and you think they were selling something really nice. It's a beautiful website. And they talk about how nice it is and how pretty it is and how they make all these little extras you can hook on, like a silencer or a flash suppressor. Well, why would you have to make a silencer for a civilian weapon? Think about that for a minute. That really doesn't make a lot of sense to me. But I'm sure the gentleman who bought the weapon, who was up there in Las Vegas, thought about that, about maybe getting a silencer for his weapon. But next slide, please. But their website shows a nice couple holding their weapon, and they have kids in their website talking about gun safety. It's a very disingenuous website. Makes you really think twice about what's going on in our country when you see websites like that. Next slide, please. So what can we do? Well, to quote Tip O'Neill, all politics are local, to go back to what Marion was talking about. Do you know your local state representatives, senator, party officials? Do you know your mayor, city council members, school board members? These are the people that make the rules. Like this state in Ohio, basically anybody can buy a weapon. There are no requirements to get training. Ohio is very much like Texas in terms of, what rules there are. Are you participating in local charities, boards, foundations, other community organizations that widely represent your constituents? And if you're not part of the solution, you're part of the problem. Simple as that. What are you doing if you really feel strongly about these issues, what you need to do is get involved at some level in your community, and you got to figure out what that would be, whether it be city government, state government, or federal government, to try to get control of these things. I just pointed out what goes on with AR-15s, but we are awash with guns in this country. Until we do something about it, nothing will change. And I have met the enemy, and he is us.
I hope we didn't bore our international audience too much, but this is the leading cause of death in children, and our job is to take care of children. So thank you for including this topic in this course, and I hope in a few years we won't have to talk about it because it will no longer be a problem here as it is worldwide.
All right, thank you so much. Obviously an important topic. Thank you, all of you, touching on this. It was a controversial topic, but it's important, so thank you. We're going to take a very brief break, and when we come back, we're going to get into no more virtual faculty, so we're done with the Zoom issue, but we'll get back on track with the rest of the event. So we're going to move on to gastroschisis, and then several other hot topics, and we'll see you in a minute.